so just going to give you a few thoughts about the new era of practice. We just had a session on Affordable Care Act, on what we're doing in quality improvement in IBD, and how are all of our daily lives changing as we try to take care of patients in this new era. I'm going to give you some updated data from primary care and then try to transition that into talking about oral IBD meds. And this is a nice segue that Bruce set this all up for me. You can't optimize therapy that the patient isn't taking. So I think it's really important that you first get it into the patient before you think about how you're going to optimize it. We're going to talk about some biologics and then and some non-therapeutic areas and what we know about adherence to taking care of our patients in other ways. And then I'm going to share with you the future. All right, so I want you to keep in mind perspective. As you're taking care of that patient, what you think is appropriate, what you think is cost effective, what you think is low risk or safe, the patient doesn't see it that way. So you have to remember the perspective of the patient and where they're coming from, because if they're not on the same page as you, you're dead in the water. So this picture is actually the Thames in London, and I was there at the beginning of September, and I took this photo, and this is the definition to a Londoner of a sunny day. Okay? When I got out of the cab, I said, oh gosh, I thought it was supposed to be sunny today, but it's all cloudy. And he goes, it's not raining. This to us is sunny. So this is perspective, and you have to keep it in mind when you're talking to your patients. All right, so it's really interesting how evidence has now evolved into practice. So we have this big bucket here of clinical research, which starts as clinical studies, and that's proving safety and efficacy. And then after a few trials, we do some systematic reviews to prove that, yes, something actually does work. And that's all research synthesis. And then as we move forward with trying to take care of patients, we move into this evidence-based medicine sort of transition. And that's where we talk about clinical care research. Health services research is a new area that people are starting to talk about. You'll hear Gil and Corey talk about these things. And what's interesting is that clinical decision-making seems to have come at the end after we have all of our evidence, all of our scientific data in, but it has to be agreed upon and adhered to. Those are the last two boxes, and maybe that's the most important. You can spend literally millions of dollars proving that a drug works, but if a patient isn't buying it, then there's no point in even talking about trying to give it to them. So where are we? In the IBD literature, this is actually a very nice summary paper that was published just last year in the IBD journal. In talking about adherence to therapy in the IBD world, there has been one paper looking at educational intervention, two papers looking at behavioral intervention, another looking at cognitive behavioral intervention, 6 that look at multi-component interventions, and of all of that literature, none have shown to increase adherence greater than 6 months at a time. So the big picture here is that you can do small things for short amounts of time, but that patients will change in terms of what their insurance coverage is, how they're feeling, what their hairdresser's second cousin's dog walker has now told you, what they've read on the internet about the medicine that they're on, so that you have to make sure that you know that you are not going to be able to change behavior for more than just a few months at a time. So this is a really interesting study out of the Annals of Internal Medicine published this year. This was looking at primary non-adherence. So what's primary non-adherence? This is not filling an incident prescription within 9 months. So we're not even asking the patient to go to their Walgreens right after the appointment, but giving them 9 months to have this prescription sitting around that their symptoms get so bad that they finally go to fill this prescription. So this is a Canadian primary care network with very robust, rich data for looking at a single payer system where prescriptions are very well classified and recorded. It turns out that out of 37,000 prescriptions, 31%, so a good third of patients were not, or those prescriptions were not filled. And which ones were not filled? Turns out that if they were in the upper quartile of cost for that drug class, if they were for dermatologic issues, and then I've underlined gastrointestinal. So that all means us in the room here. So that's usually going to be the patient who has refractory reflux or GERD or dyspepsia or whatever. These patients are complaining, but yet they're never filling the prescription that you write for them. And it's interesting that also for autonomic conditions are much less likely compared with antibiotics. Those are the ones that your patients will fill. Even when they have a viral illness, they're still filling the antibiotic prescription. It turns out that older age of the patient, a co-pay coverage system, and more visits with the MD are protective against non-adherence. So a patient who isn't going to have to pay a lot for that prescription, so no skin in the game for them, and if they have a good working relationship with their physician, with a lot of visits, that is going to portend a better adherence to filling. This is another really interesting Annals paper that came out this year. It turns out that appearance does matter. This is a United Healthcare database out of the US. These were medications prescribed following hospitalization for an acute MI. So 4,500 single episodes of non-persistent medication use were studied, and it turns out that if you changed the pill color on the patient halfway through their course, that there was a 30% more likely chance that they weren't going to take it because you changed the pill color. And if you changed the pill shape, 66% of the time they were going to be less likely to take it. So and these effects did not change even in multivariate analysis when you looked at their Carlton, their comorbidity index, their gender, or their age. And so just switching on the patient makes them somewhat distrustful of what you've done, and that they were used to something and you've changed either the pill color or the pill shape and now they're not going to take it. So appearance does matter. All right, so now we switch back into the IBD world, and this is looking at a different aspect of what we do. And in the session, for those of you who may have been in the other session on the other side of Dade County over there that we did earlier, Miguel Reguero was talking about the IBD home, and that a lot of patients are on narcotics and other therapies, and for sure polypharmacy is a growing concern in our IBD population. That the IBD patients looked at from this study in the Thomson Reuters Market Scan database compared to healthy controls, well, half of them, compared to a third, were on narcotics. 13% were on non-narcotic analgesics versus only 8% of healthy controls. Antidepressants, almost a third versus 1 out of every 5 of healthy controls. And then they actually grouped psychiatric meds separately than antidepressants. And that 26% of IBD patients were on psychiatric meds as compared to 17%. So there's a lot of other stuff that maybe we're not prescribing that is certainly playing into how well the patient feels and how motivated they are to take the medicines that you want them to take. All right, so Alan Moss in Boston has done this very nice work looking at attitudes to mesalamine. So we'll start with sort of the lower rung of in terms of toxicity and cost. So this is a validation study of a survey to try to predict non-adherence to mesalamine for ulcerative colitis. So we have other survey tools available to us. We have the Maritsky scale that's now down to 8 questions, and we have the medication possession ratio if you want to actually call the pharmacy to find out. But obviously those things are time consuming, and we don't have the kind of resources to do that for every patient. So what they've done is they were able to come up with a new survey and compared it to the MMSA-8, the NPR at 12 months, and urine levels of salicylates. And what they found was that the patient belief in the importance of maintenance medication when in remission and the concerns about the side effects were the 2 items that correlated best with all metrics. So basically, if you ask your patient, do you think it's important to stay well and be on your medicine? And do you think that it's safe? Those 2 questions are just as good as looking at the NPR or even urine levels of salicylates. So I look forward to seeing more data in a larger population out of Boston to see whether we can actually correlate and replicate this work. This is so new that it's EPUB ahead of print even. So this is to come. All right, for those of you who need to answer correctly for the post-test, here is the slide for one of the questions, and this was the systematic review of adherence to anti-TNFs. Now, this is a European study, so it only included adalimumab and infliximab because most European countries don't necessarily have certolizumab available to them. This was 13 studies. Now, think about it, 13 studies that looked at adherence to anti-TNFs in the IBD population, looking at almost 100,000 patients. The pooled adherence for an anti-TNF therapy for IBD was about 83%, but the range was quite large at 37 to 96%. Overall for adalimumab, about 83%, and overall for infliximab, only 71%. And you'd think, well, wait a minute, they have to come in for infusions, we have more control, but it doesn't seem to matter. Patients with Crohn's disease were much more likely to be adherent than those with ulcerative colitis. And the most reliable predictor of non-adherence was actually female gender, not male gender, followed by smoking and then psychological disease. Well, we already heard Bruce talk about some of the cost issues and strategies involving cost associated with biologic use. You have the cost of the drug, but then you have the secondary costs and the indirect costs. And this was a very nice review article actually written by pediatricians and published just this year in the IBD Journal. But strategies to reduce costs, i.e. trying to get your patients to buy into this and keep them adherent, includes the things that Bruce has already talked about, so it's a nice way to sort of just bring that back and emphasize some of these things, is to eliminate the episodic dosing, and that accurately determining the indication for escalating that dose, i.e. make sure that they actually have active inflammation and not irritable bowel syndrome or C. diff, something else that's driving GI symptoms. What we still need to work out, as Bruce already pointed out, do sub-Qs, are they really cheaper? What about combination therapy and then therapeutic drug level monitoring? And then do we really need to get to complete mucosal healing? And I know that there's going to be debates about that as well. So also out of the Boston group is Sonia Friedman's work that got published this year in the IBD Journal. And this has to do with a new concept called self-efficacy. So self-efficacy beliefs have significant effect on how a person will persist in performing a task over time, how much effort a person will expend, and how engaged the person's coping behavior when a skill is mastered. And I took that entire phraseology word for word to just make sure you understood what self-efficacy was. And the range is anywhere from, I can't do that at all, to, I'm very highly certain I can do this. So this was looking at a survey of 20 items for surveillance colonoscopy. How willing or how able are you to come in for your surveillance colonoscopy? So from 20 items, they were able to refine it down to 11, and then they got it down to 8. And the adherence, if they scored well on these 8 items, actually scored very well, and the accuracy was 74%, which in this scientific realm is actually pretty high. So here are the 8 questions that they accept the news that it's time for their procedure, right? So you're in clinic with that, oh, it's time for your surveillance colonoscopy, and you get the dreaded, oh, really? Oh, can't we put this off another year? Is it really time again? And they're not really happy to hear that news. How accepting are they? Can they schedule the procedure? Well, that seems pretty easy, but sometimes if you have a very clunky system and that they have to go through 4 or 5 branches of a phone tree to get even to schedule it, or they're like, oh yeah, sure, no problem, it's one phone call, but it's going to be the next Thursday after the harvest moon, well, then that's not going to work for them, so scheduling is still difficult. Taking the prep, tolerating the prep, so if people will take it, but if they throw it up, they didn't tolerate it. Avoid eating solid foods prior to. Well, a lot of people just say, I can drink that stuff, give me two courses of it, don't take away my Big Mac. Can you drink enough clear fluids? Remember, everybody wanted to do the Fleets phosphosoda because it was just a little bit. Why did we take Fleets away from people? It's because it was causing renal toxicity and cardiac arrhythmias, because people just wouldn't drink enough to flush out what the Fleets was doing. Can the patient recover from the side effects? Yes, they're willing to go through it, but they're like, God, I am so wiped out the next day. I just really don't want to do this, and I dread it. And then, interestingly, can the patient enjoy the rest of the day after the procedure? So whether that means that they got propofol and they're awake and that they've got the rest of the day off and they can go, or are they in discomfort? Are they so groggy that they don't remember anything? I've had patients come back and say, my wife took me shopping and she has this beautiful new piece of jewelry and I don't remember, and it's your fault, Dr. Kane, because of that Versed. So it's interesting that things that we wouldn't think about as physicians or providers, these are items that the patients came up with and got it down to a very nice, simple 8 very clinically relevant, patient-centered questions that can help you decide whether that patient's actually going to show up for that surveillance colonoscopy. And where is it that you need to have that discussion about coming in for that? All right, so if we switch gears again, and not medicines and not surveillance colonoscopy, but we all understand that the DEXA scanning can be important for our IBD patients. So this is Nabil Khan, and he has access to the nationwide VA population, so a very robust number. These are patients who have IBD treated within the VA system who were exposed to steroids. Out of 5,700 patients, 1.4% of them had fragility fractures, as documented in their medical record. And interestingly, adherence to AGA guidelines for DEXA scanning in those patients who had a documented fragility fracture was only 23%. Now, okay, that's bad enough, but what's really interesting is that those who had had a DEXA scan were half as likely to have developed a fragility fracture in the first place. So the hazard ratio of 0.5. So if there's a compelling reason to do the DEXA, it's to screen against that patient developing a fragility fracture. All right, so here's the future. I'm so excited about this to share it with you. So this is the website of Proteus, and this is a digital health feedback system. So this is almost like Homeland, for those of you who watch it and are addicted like me. So this is their website. So what they have developed are little monitors that are the size of a grain of sand, and they can be adhered to individual pills or capsules or tablets, and then dispensed to the patient. And when that capsule or pill is ingested, it sends a signal from the stomach to a little device that the patient is wearing, a little Bluetooth device, and then that data are shared onto some electronic database. So this is meant to be for dad who has some Alzheimer's and you're not sure that he's remembering to take all of his pills. But the future is wide open for patients who are at big risk for flaring, who just don't necessarily remember to take their medicines, and if it's once a day and they do very well and they need to have therapeutic levels of their thiopurines, that this is the way that you know that they're taking it. Now maybe it's going to have more relevance in a pediatric population, but it's so interesting that the technology has gotten from MEMS caps, where we had the big bulky caps, and when you opened the cap, the bottle is when it sent a signal, to now grains of sand on individual pills. So that's how far we've come, and this is the future for potential adherence. So in summary, non-adherence is still prevalent, because I showed you the infliximab data as well as the adalimumab data. There is still no good, reliable, or cheap way to change long-term behavior. We have colleagues out there who are trying to figure out how to do this from a patient-centered way, that we ask them what's important to them to get them to change their behavior. Not all meds have the same issues, and not all patients have the same issues. So this has to be individualized, and you have to figure out what it is that's driving them. So I'll end with this. This is the smart dog. He picked his battle. So pick your battles. We realize that we have a limited amount of time with each one of our patients, and as we're sitting there with new EMRs, and we're sitting there with quality metrics that we have to fill out, and we've got the portal messages and the emails, and our pager is going off, that obviously we can't be sitting there and asking them all of these questions about, so how do you feel about your medicine today, Mrs. Jones? But so pick your battle, and that just keep some of these things in mind, because maybe that you're not thinking about therapeutic monitoring because that patient's not even taking their medicine, and that's the battle you have to have today. So appreciate your time and your patience and your attention, and I'll turn it over to the next speaker. Thank you very much.